So today we have the honor and privilege of listening to Dr. Susan Ellsperman, who is one of our own, is going to talk about tinnitus, pathophysiology, and updates on treatment options. And so we look forward to hearing what our updates are. Susan, thank you very much.
Thank you. Okay, so as Dr. Slattery mentioned, thank you for the introduction. I'm a first-year fellow here at House. This morning I'll be discussing tinnitus, its pathophysiology, and where things stand with current treatment options. I have no financial disclosures or conflicts to report. I'll mention a few commercial brands, but it's not meant to be an endorsement of any one of them. And my only personal conflict is that I have chronic tinnitus, and it would be really great if there was a simple and effective treatment that would make it go away. So tinnitus is often defined as the perception of sound without an external stimulus. Humans have likely always experienced tinnitus. There's a little bit of controversy over when the first documented description was made. Most sources cite an Egyptian medical text from the 16th century BC, which referred to tinnitus as the bewitched ear. But others give credit to the Greek text Corpus Hippocraticum, which dates to the 3rd century BC, which included a more thorough description and treatments. Some of these early treatments included sticking reeds in the ear canals, chanting incantations, or putting earthworms boiled in goose grease in the ear canals. Unfortunately, we've made a little bit of progress since then. Despite being described and recognized thousands of years ago, we still don't have a full grasp on the pathophysiology of tinnitus and how to best address it. The lack of effective treatments is not due to a lack of interest. This graph shows just the number of publications on PubMed with the search phrase of tinnitus. Over the past 2 years alone, there were more than 1,100 articles published per year, and already 200 articles published in January and February of 2023 alone. So with all this out there, deciding what to include in this presentation was a challenge, and it will in no way be comprehensive. But this morning, I'll discuss only non-pulsatile subjective tinnitus, assuming that imaging and medical workup did not reveal a treatable cause. I'll begin with a little bit of epidemiology, the pathophysiology of tinnitus, current treatments, and future directions. Chronic tinnitus affects at least 10 to 15% of adults, and some sources state that up to 40% of adults will experience tinnitus at some point in their life. It's estimated that 50 million Americans currently have chronic tinnitus. Most studies show a slight male predominance overall, but affects both sexes relatively equally. Most patients with tinnitus have some degree of hearing loss, but at least 10% have a normal audiogram on conventional audiogram testing. The incidence increases with age, and tinnitus is most common in those over 60 years old. Only about 20% of people will seek clinical evaluation from a physician or an audiologist, and about 1 to 3% will have very bothersome tinnitus that significantly impairs their quality of life. This represents about 2 million people in the United States alone. Just looking at the House clinic experience, we see a lot of patients with tinnitus. From 2018 to 2021, we saw more than 14,000 patients for tinnitus, including more than 3,800 in 2021. Some of the best publicly available data comes from the US military. Tinnitus is a problem for many veterans of the US Armed Forces. This is from the Veterans Administration Annual Benefits Report just published in 2022. Tinnitus remains the top service-connected disability overall, with a total of 2.7 million veterans impacted. Hearing loss has historically been number 2, but fell to number 3 last year, affecting 1.4 million Americans. So I think this helps highlight the immense burden to people with tinnitus and the financial burden that can accompany it. While hearing loss and increased age are associated with most cases of tinnitus, other studies have recently found a significant genetic component. And this comes from a Swedish study by Moss et al. Evaluating more than 70,000 twins. H2 in the second column is the heredity factor, which is an estimate of the genetic contribution to a condition. And C2 and E2 are environmental factors. So the heritability factor was the highest in those with bilateral tinnitus, which makes sense. Male twins had higher heritability estimates than female twins, and the heritability factor was 0.68. Which is a value similar to conditions like ADHD and autism, which have well-established genetic contributions. Researchers have started to identify single nucleotide polymorphisms and specific genes that might play a role in understanding who will be susceptible to developing chronic tinnitus. These definitions are from the Academy of Otolaryngology clinical practice guidelines that were published in 2014, and they describe 6 distinct groups of tinnitus patients. And the group of greatest concern are those with bothersome tinnitus. They represent about 1 to 3% of patients and have significantly impacted quality of life and distress. They're at risk for serious mental health concerns, worsening of pre-existing conditions, or even suicidal ideation. Most of the emerging tinnitus treatments are aimed at this group of patients because they're desperate to try anything to get some relief from their ringing. This figure was recently published in the White Journal by Grunfest and Jamil, and I think explains really well the vicious cycle that we see in so many patients with bothersome tinnitus. It's been well established that tinnitus is directly related to stress, sleep, anxiety, and depression. And many patients fall into these cycles. So tinnitus impacts the ability to fall asleep, which leads to worsening insomnia. Lack of sleep exacerbates tinnitus, which then makes it even more difficult to fall asleep. Likewise, stress can trigger or exacerbate tinnitus, and tinnitus can cause anxiety or worry, or anxiety due to worry about the etiology or worry that the tinnitus will never go away. And increased anxiety leads to worsening tinnitus, and the cycle begins again. So especially in patients with underlying anxiety and depression, this can be life-altering and all-consuming. So what's happening? Why do people develop tinnitus? So we know that multiple factors contribute to the onset of tinnitus, but when and why this occurs in certain patients is not always clear. Known contributing factors include hearing loss, ototoxic medications, head and neck injuries, and emotional and attentional input. The term maladaptive plasticity encompasses the central changes that occur and lead to tinnitus development. This figure comes from a paper in Nature Reviews by Dr. Susan Shore at the University of Michigan. It's a great overview of maladaptive plasticity and the pathways known to be involved in tinnitus pathophysiology. The blue boxes show a simplified version of the auditory pathway, beginning at the cochlea at the bottom of the image and follows along to the primary and secondary auditory cortexes. The dorsal cochlear nucleus is the first site for most multisensory integration and receives input from the auditory nerve, auditory midbrain, auditory cortex, trigeminal and cervical ganglia, and others. Also shown here are other central and peripheral pathways that contribute to the production of tinnitus and an individual's response to it. In red are the sensory motor pathways, including cerebellar and somatosensory contributions. Somatosensory inputs include muscles of the jaw, neck, or shoulders. In yellow are the memory and emotional processing centers, which include the hippocampus and amygdala. In green are contributions of attention and consciousness, including the cingulate gyrus and the frontal and parietal cortexes. This is an oversimplification, but current treatment options attempt to address each component of this pathway. From functional MRI studies, we know that these areas of the brain are active and involved in tinnitus perception. This is from a 2021 study by Hugh et al., but many prior investigations had similar findings. This figure shows multiple areas involved, including the auditory cortex, of course, in red, and important contributions from the limbic system circled here. The limbic system contributes to the emotional reaction to tinnitus and likely the persistence of the sensation. And these functional regions are common targets of transcranial magnetic stimulation, which we'll discuss a bit later. Within the auditory pathway, there are certain changes on a cellular level that have been identified to contribute to tinnitus. At the top of the figure, it shows damage to auditory nerve fibers. This is listed as noise exposure, but could be anything that causes damage to the auditory nerve fibers. A decreased number of nerve fibers or decreased firing rate leads to changes at the cellular level and to ion channels, which alters the release of neurotransmitters and induces changes at the synaptic level. This corresponds to changes in the number and activity of potassium and HCN channels. HCN channels are hyperpolarization activated cyclic nucleotide gated channels, as well as NDMA receptors. When synapses are modified, neurotransmitter production and release can also be impacted. Prior investigations have shown that changes occur which lead to an increase in glutamate transmission. Glutamate's a major excitatory neurotransmitter in the nervous system. And similarly, there's a decreased transmission of GABA and glycine, which are major inhibitory transmitters. Upregulation of glutamate coupled with downregulation of GABA and glycine lead to increased spontaneous firing rates, increased synchrony, and changes in plasticity, which all lead to tinnitus formation and persistence. Because there are neurotransmitters and ions at play, these become potential additional targets of tinnitus therapies, which we'll discuss a bit later. So how do we treat tinnitus? Where should patients start? There is an ever-growing number of recommendations you can find online. I'm just looking around. I even found a book that's been published citing 100 remedies to try for tinnitus. It's available on Amazon. It can be very confusing and overwhelming for patients to know where to start. Dr. Brackman has a statement. He often tells patients with tinnitus that the number of treatments for any condition is inversely proportional to the effectiveness of any one of them. And I think, unfortunately, that's been true for tinnitus up to this point, with hundreds or even thousands of potential treatments or remedies out there, and none that stand out as that effective. For the 1 to 3% of people with tinnitus who have significant distress and impacted quality of life, they come in hoping for some relief of their symptoms. So what should we offer them? Listed are some of the categories of therapy aimed to either reduce the volume or intensity of tinnitus or decrease the negative impact of tinnitus on quality of life. The first group includes vitamins and supplements. Many have been recommended, including lipoflavonoids, nicotinamide, ginkgo, and others. One meta-analysis suggested there may be benefit with ginkgo compared to placebo, and subjectively, many patients do report an improvement with use of these supplements. The clinical practice guidelines previously published by the Academy actually recommends against offering dietary supplements as a treatment, but they are inexpensive and overall safe, so they're widely used and prescribed. Other treatment categories that we'll cover include hearing restoration, sound therapy, biofeedback, and cognitive behavioral therapy, novel medications, new devices, and external stimulation. Hearing aids are helpful in many patients and should be recommended to anyone with hearing loss, but the benefit is likely due to a masking effect of amplifying environmental sounds. Hearing aids can also decrease listening effort and can lead to improved emotional well-being by being able to more fully participate in their family and social environments, but hearing aids don't address the underlying etiology of tinnitus. Cochlear implants and ABIs have been found to be quite helpful. In CI literature, it's been well established that tinnitus suppression is likely to occur after implantation. Most studies report about a 70% rate of improvement. There was a nice meta-analysis published by Ewan et al. Out of MUSC in 2021, which reviewed studies including more than 1,200 patients. Reported rates of improvement in tinnitus were 15 to 83%, depending on the study. And there also seemed to be a trend that those with worse tinnitus to start had a greater degree of improvement. And this could be due to masking as well, or reversal of central tinnitus mechanisms by stimulating the deafferent neurons, or also a placebo effect due to improved quality of life and decreased stress with improved hearing after a successful cochlear implant. The ABI has also been shown to be helpful. ABIs are typically reserved for patients with an F2 or an anatomic reason they can't use a cochlear implant. In addition to providing hearing benefits, it makes sense that ABIs could be useful for tinnitus because they stimulate the dorsal cochlear nucleus directly, and we know this plays a major role in generating and modulating tinnitus. The first report that an ABI could be helpful was by Saucy et al. And Otto in 1994. They reported on 7 patients with NF2 who were using their ABIs daily, and 6 of the 7 patients reported an improvement in their tinnitus. Another study by the House Group in 2017 also reported a positive benefit. This was published by Roberts et al. And included many of our current faculty as authors. They had 43 survey responders with ABIs. 54% reported that using the ABI reduced their tinnitus loudness. 61% said that tinnitus was only improved while they were using the implant. There may be ways to take advantage of tonic or repetitive stimulation of the dorsal cochlear nucleus to modulate tinnitus, though, separate from just providing hearing input. A group out of the Netherlands is exploring this now, and they're currently recruiting 10 patients for a clinical trial to implant ABIs in patients with incapacitating unilateral tinnitus. This is an active study, and we'll try to evaluate if certain patterns or modes of stimulation are effective for tinnitus improvement. Unlike a cochlear implant, an ABI could be placed without compromising a patient's hearing. So this trial is still recruiting, and there'll be more to come on that topic in the future. So our next topic is sound therapy. This includes simple masking and formal tinnitus retraining programs. Simple masking can be very effective for patients to instantaneously reduce their tinnitus burden in bothersome environments and help with sleep onset. Formal tinnitus retraining therapy was established in the 1990s, and it's a comprehensive program we'll touch on next. Tinnitus retraining therapy, or TRT, was first described and popularized by P.J. Jabelstroff, a PhD at Emory. Many patients or many programs are advertised or described as TRT, but to truly meet criteria, programs must include a structured counseling program in addition to sound therapy. The counseling portion is really critical. It provides education to patients and helps them reframe their tinnitus and remove the negative associations with it. So this is crucial for the sound therapy to be effective. And sound therapy is designed to introduce non-annoying background sounds, often including wideband noise at a low volume that can be delivered through hearing aids, headphones, or external devices. The goal of traditional TRT is to play the sounds at just below the mixing or blending point, which is the volume at which the volume of the sound and the tinnitus start to mix or blend together. So the sound used in TRT should be played at a volume just below this mixing level where the tinnitus is still distinctly heard. In initial studies, patients were instructed to use this treatment for 8 hours per day, and habituation and improvement were thought to happen over 3 to 6 months of therapy. There was success with this method and has been repeated in other studies. TRT has been around for now more than 25 years, and overall the rate of improvement in patients is cited at about 80%. This was one trial comparing masking to TRT. This group included 123 veterans, and the vast majority were men. They were randomized to receive either masking therapy or formal TRT. Both groups were provided with noise-generating devices with a built-in hearing aid if needed, and the TRT group received the structured counseling and strict criteria on how to use the device and to use it for 8 hours per day. The masking group received a little bit of general education, but were allowed to use their devices in any way to mask their tinnitus, and there were no recommendations for how long to use it or that they should wear it every day. Several questionnaires were administered at the start and at 6, 12, and 18 months of treatment. I'll just highlight 2 of their outcomes here. The first are tinnitus handicap scores. There was an improvement in all groups, but the greatest improvement were those that went through TRT, and there was more improvement in the groups of patients whose tinnitus was more severe to start. So you can see in the open square that with a dashed line, it represents those with who went through TRT, who described their tinnitus at the beginning of the study as being a very big problem. Their THI scores were the highest at the start and improved by the greatest degree by the end of the study. Similarly, this shows the percent of awake time that patients were aware of their tinnitus. All showed significant improvement from about 60 to 80% of the day at baseline to 15 to 40% after 18 months. Again, the greatest improvement was in the group with very bothersome tinnitus who went through TRT. Specific customized programs and devices are available for patients to purchase. One of the most well-known is Neuromonics. In the traditional program, there's a preconditioning stage, which is more like masking and just designed to provide instant relief and some reduction in tinnitus intensity and improve sleep onset. And then the conditioning stage is more similar to traditional TRT, in which a signal is played just below the level of tinnitus in the mixing or blending volume range. Typical treatment is about 6 months. The benefits of these devices have been replicated in some studies, including this trial in which Dr. Luxford was a senior author. There's a significant improvement for most patients. In this study, there were improvements at 1 year in nearly 80% of the study group, and the benefits persisted at 2 years. The original devices that utilize this plan can be very expensive, up to $5,000, which is cost prohibitive to most people. As smartphone technology has improved, these programs can now be offered via app-based delivery methods, which lowers the cost to only about $250 per year. Modifications to TRT have been made in regards to the way sound is administered, including which bandwidth should be delivered. And this could be broadband noise, white noise, pink noise, music, or even pitch matched. Dr. Slattery was a senior author on this paper showing that S-tones can be more effective and less bothersome to patients compared to broadband noise. S-tones are pure tones with a carrier frequency that is pitch matched to an individual's tinnitus and then sinusoidally amplitude modulated, in this case at a rate of 40 hertz. This was the approach used with the Serenade device from SoundCare. In this figure, you can see that about half the study group felt that their tinnitus reduction was better with the use of S-tones compared to traditional broadband noise. Some patients have tremendous benefit from these programs, but there's not a 100% success rate, and it's unclear who will benefit the most from these TRT programs. Other than cost, they don't add additional risk to patients and can be very successful for some people. So beyond sound therapy, we'll move on to biofeedback, mindfulness, and cognitive behavioral therapy, or CBT. Dr. House wrote a lot of the initial work on biofeedback or neurofeedback, which is the concept that patients can learn to consciously control certain areas of the body and physiologic responses. These results are from a study he published in 1978. In this group of 41 patients, 80.5 had improvement initially, and 56% had sustained improvement in their tinnitus at 6 to 12 months. These methods can be very helpful in appropriately selected patients, and many find that they are able to gain additional insights and influence over other areas of their mental and emotional health by becoming adept at the practice of biofeedback. This requires buy-in from patients and a lot of time investment. It can be very effective in modulating a patient's response to tinnitus. There are therapists and centers available that focus on this process, and it can be very helpful for a lot of people. Cognitive behavioral therapy is really the only treatment for tinnitus that it has displayed reproducible benefits when compared to a placebo and has been validated in systemic reviews and meta-analysis. CBT was initially developed by a psychiatrist named Dr. Beck in the 1960s and is used initially for depression. Since then, it's been modified and used for decades for other diseases like anxiety, insomnia, eating disorders, PTSD, addiction, and many others. CBT traditionally includes psychotherapy or talk therapy and is comprised of psychoeducation, relaxation, exposure techniques, behavioral reactivation, and mindfulness-based training. It attempts to modify 5 components, which include bothersome situations, thoughts and emotions surrounding the condition, physical feelings and actions surrounding tinnitus, and it's been adapted for tinnitus specifically and works mostly to modulate the individual's response to their tinnitus. It does not change the loudness or the quality of the sound. A Cochrane review published by Martinez de Besa et al. In 2007 and updated in 2010 found that there was no difference in tinnitus loudness with CBT, but there was a significant improvement in depression scores and quality of life in patients that utilize CBT. Finding a therapist familiar with CBT for tinnitus can be challenging and requires a lot of cost and time commitment by patients. Sessions are typically once a week, and this is meant to be only a short duration of therapy, not lifelong. This typically is performed in 8 to 24 sessions, which will cost at least $100 to $200 per session. So this can also be up to about $5,000, which is cost prohibitive to many people and unfortunately unlikely to be covered by insurance. There are multiple online and virtual options, which makes this more accessible and convenient, and even online group CBT options, which can be much cheaper. One benefit of the pandemic is that many therapy options move to a virtual format, and there are several therapists who advertise online CBT for tinnitus. And this is one by a therapist named Dr. Bruce Hubbard. It's very popular on tinnitus support pages. This is a graph he has on his website, which I thought was a good visual showing the goal of CBT. Even though tinnitus stays the same, as shown here in blue, your reaction to, distress from, and awareness of tinnitus can change drastically. So most of what we've talked about up until this point has been treatment aimed at masking the problem or managing the impact of tinnitus, but the next 2 categories aim to treat the underlying pathology. So next are the novel tinnitus medications. Dr. Barani reported that temporary improvement or resolution of tinnitus was possible with the use of medications. In this study, he injected a mixture of Novocaine and adrenaline, either subcutaneously or IV, into patients with tinnitus. 80% of patients had a temporary resolution of their tinnitus that lasted up to an hour. This was the first demonstration that a medication may be able to treat tinnitus. It's impractical and unsafe to give systemic lidocaine on a continuous basis, but this was the groundwork for the use of medications to halt tinnitus. This was in 1936, almost 100 years ago, and still no effective medication is available. This is a list of just some of the medications and medication classes that have been utilized in the past without consistent benefit. Anticonvulsants and antiarrhythmics are similar to Novocaine and lidocaine in that they also act as sodium channel blockers, but thus far they have not produced the same reduction in tinnitus. Antidepressants and anxiolytics have a role in those with tinnitus and comorbid anxiety or depression, but not as a primary tinnitus therapy. This table is published in a review article by Sederoth et al. Describing some of the recent medication trials, many of which have unfortunately failed. The drugs are divided into anti-excitatory, vasoactive, or other categories. I'll discuss some of the anti-excitatory medications. Novel drug therapy has been aimed at addressing the ion channels and function of neurotransmitters to decrease spontaneous firing rates and synchrony within the tinnitus pathway. The first 2 drugs we'll discuss impact potassium channels and HCN channels. First 2 I will start with are oral medications. So the first is AUT00063, which was developed by the University of Nottingham. The trial was called the QUIET or Quest in Eliminating Tinnitus trial. And this drug targets voltage-gated potassium channels, specifically Kv3.1 and Kv3.2. This medication has shown promise in rodent models. It suppressed spontaneous hyperactivity in the dorsal cochlear nucleus of a hamster and in the multi-unit activity of the inferior colliculus of a mouse model. This was a phase 2 trial in humans. It was randomized, placebo-controlled, blinded, multi-center trial. And as I mentioned, this is an oral medication. The study arm was patients were given 800 milligrams of oral drug per day compared to a placebo, and it was administered over 28 days. The primary outcome were TFI scores. And so you can see here, these are the results from 36 patients who received the study drug and 40 patients who received the placebo. Negative values indicate an improvement in TFI score. So the outcomes were not better in the treatment arm. In fact, for most TFI subscales, the placebo actually performed better. This drug was safe, but did not show much promise in this trial. And it was very effective in rodent models, but at least this human study didn't show much efficacy. This highlights the disconnect that can occur between human and animal models, which makes this work even more challenging for researchers. The next drug is BGG-492, also called celerampanel. And this is manufactured by Novartis and functions as an AMPA kainate receptor antagonist, which is a type of glutamate receptor. This is an oral medication that's been used in trials as a potential epilepsy drug as well. The results of this trial were published by Kucher et al. In 2020. This trial had a complex design as a phase 2A proof of concept study. It was randomized, double-blinded, placebo-controlled, and had a crossover period. Patients were administered 100 milligrams of the drug TID, but the dose was reduced to 50 milligrams TID if there were issues with tolerance. They used a visual analog scale and the TBF-12 tinnitus impairment questionnaire. An improvement by greater than or equal to 4 points on the scale was considered a significant improvement. So a significant improvement was seen in 26.7% of the treatment arm and only 14% of the placebo arm. So this was deemed sufficient to achieve their proof of concept. There were a lot of adverse events in this trial, though. In patients that received the 100 milligrams TID of the drug, 86% had an adverse event compared to only 57% of the 50 milligram group, 48% of the placebo. The most common were dizziness, fatigue, and headache. Not much else has come out about this drug since this trial was published. Other articles have speculated that this glutamate receptor is ubiquitous and nonspecific, so it might lead to a higher than acceptable incidence of adverse or unwanted effects and limit its use as specifically a tinnitus target. The next two medications are delivered via IT injection and aim to target the NMDA receptors. The first is AM-101. This was developed by RS Medical as an IT injection. The active component is S-ketamine hydrochloride, which is an enantiomer of ketamine and functions as a non-competitive NMDA receptor antagonist. One of the pathways of development of tinnitus is cochlear excitotoxicity that occurs after acoustic trauma, hypoxia, or acute infection. And this is characterized by excessive release of glutamate, influx of calcium through NMDA receptors, disruption of postsynaptic structures, and even neuronal death. So the purpose of this medication is to block this excitotoxicity pathway in the acute phase of tinnitus before tinnitus becomes centralized or chronic. This first paper describes results from a phase 1 and 2 clinical trial. It involved 24 patients with a recent onset of tinnitus within the past 3 months and who were very bothered by their symptoms. All had been treated with prednisone for acute noise trauma or sudden sensorineural hearing loss. Participants were given 1 injection and then tested at days 7, 30, and 60. Tinnitus loudness, tinnitus handicap, and minimal masking level, or MML, were recorded. The results are listed here. Results for the THI are not that impressive. The response rates were similar in the placebo and the trial group, but there was a significant improvement in tinnitus loudness and minimum masking level for the treatment group compared to the placebo. The MML is the level of masking that's required to block tinnitus perception, and it's one way to try to quantify tinnitus loudness. A more recent phase 3 trial was also completed and was designed to look for adverse events, in particular hearing deterioration. They considered a change in bone conduction thresholds by 15 decibels to be meaningful. So there was a similar rate of hearing loss reported in the treatment group and the placebo group. The treatment group's on the left, the placebo group is on the right. The black boxes represent the ear that received the injection, and the gray and white boxes include the contralateral ear. In the placebo group, the rate of hearing loss in the treatment arm was higher than the non-treated ear, suggesting that the IT gel itself could cause ototoxicity, or there could be trauma from the injection that could lead to sensorineural hearing loss in a subset of patients. Another NMDA receptor antagonist was gacyclidine, or OTO-313. This has been used previously in animal and human studies for neuroprotective effects after spinal cord injury or traumatic brain injury. OTO-313 is manufactured by Autonomy Inc., which is based out of San Diego. It's a lipid-based formula that can be administered via IT injection. There was an initial study done in a group of 6 patients with chronic unilateral hearing loss and bothersome tinnitus that showed a significant improvement in 4 of the 6 patients. This is a sketch from their first study in which a catheter was actually surgically placed at the round window. They even drilled some of the bony niche if needed so that the catheter could be appropriately placed. And then this drug was delivered by infusion over 40 to 60 hours. This showed favorable benefits in 4 of the 6 patients. And so that prompted them to proceed with a phase 1-2 study, which was performed on a larger group. In this phase 1 and 2 clinical trial, the drug was just an IT injection. It was not delivered via catheter or a long-term infusion like the first study. Patients were injected either with the study drug or placebo, and then the TFI questionnaire was administered at weeks 2, 4, and 8. So it's a relatively small study with 15 people in the treatment arm and 16 in the placebo arm. You can see that at 8 weeks, there was an improvement in 12.9 points in the TFI score in the treatment group, which was significantly better than the placebo group. They considered a clinically significant change to be 13 points, so they just reached their goal in this study. In theory, these medications would have shown more favorable results and better safety profiles, but there are multiple confounding variables, including appropriate patient selection, treatment timing, whether that be immediately after the onset of tinnitus or how long patients should have had symptoms in those with chronic tinnitus, the use of oral or IT drug delivery and the bioavailability of either oral medications reaching their specific targets or adequate absorption across the round window membrane and IT injections. And most of these drugs were developed in animal models, which have differences in physiology and methods of measuring tinnitus loudness, just to name a few of the things that come up when in this research. So there'll be more to come in this realm, but there are still many issues to address with drug therapy. The final group, I think, is the most interesting and includes external stimulation and novel devices. The first is TMS, or transcranial magnetic stimulation. This is utilized most commonly in cases of refractory depression, but it has been adapted for use in tinnitus as well. It is delivered via an electromagnetic pulses generated by an external coil, and it depolarizes the target cells. This is shown in the sketch here. Typically, treatment sessions are 15 to 20 minutes in length, and participants are recommended to have 10 to 20 sessions on consecutive days. There are multiple patterns and locations of delivery to target different brain centers. Low frequency stimulation pulses have been shown to be inhibitory, and that's the most common treatment modality for tinnitus. Other high frequency burst patterns have also been utilized in some studies. The auditory cortex is the most common target of therapy, but points all along the auditory cortex and accessory pathways have been utilized, and some are listed here. The results and study designs have been widely variable. Some randomized controlled trials have shown a positive effect. This is one randomized controlled trial by Fulmer et al. That was conducted at the Portland VA. It found an improvement in tinnitus severity in 56% of patients in the treatment group and 22% in the placebo group. The benefits persisted 6 months after completing the 2 weeks of therapy. TMS is non-invasive, but it can be time-consuming and expensive. It can cause mild headaches and scalp discomfort. Seizures have been reported as a potential side effect, but this is typically only a real risk in people with a history of epilepsy. The Academy guidelines previously published in 2014 specifically recommend against TMS due to lack of conclusive RCT findings, lack of benefits beyond 6 months, cost, and potential for false hope for patients. For people that do improve with TMS, this suggests that direct stimulation can be beneficial to halt tinnitus. So DeRitter and his research team have taken advantage of this and utilized implanted electrodes to directly stimulate the auditory cortex. In this study, patients with chronic intractable tinnitus underwent a functional MRI and then a trial of TMS. If TMS to the auditory cortex led to a 50% decrease in tinnitus severity, then they were eligible for a trial of an implanted electrode. In each patient, a functional MRI was used for intraoperative navigation to help place the electrode extradurally overlying the auditory cortex. Immediately post-op, an external stimulator was used and delivered stimulation to try to reduce tinnitus. If patients had an improvement, Then an internal pulse generator was implanted in the abdomen for ongoing therapy. If patients did not gain relief, they were offered a more invasive intradural electrode placement. So these pictures in the first column show the position of the electrode on a post-op CT scan, and then the arrows show overlap between the functional MRI and the catheter and the electrode placement. So these can be used intraoperatively with navigation systems. So this patient in the photos had both an extradural and an intradural electrode placed. And these graphs here in the middle show their results. So that at the top, this is looking at percent decrease in tinnitus severity, and the bottom shows a visual analog score. They separated patients into those with PT, which they call pure tone tinnitus, and WN, which is white noise tinnitus. There was also a group that had both components in their tinnitus. So the group that improved the most significantly were those with pure tone tinnitus. So these patients are shown in the white diamond here. So they had a 97% improvement in their tinnitus severity, and their VAS scores improved from 9 to 1.5. The white noise tinnitus group had a much less impressive results shown in the black triangles. And then the white boxes were the group that had both a pure tone component and a white noise component, and they had an intermediate response. So placing an intracranial electrode is quite invasive, and patients reported several side effects, including word finding difficulties, dizziness, and 2 patients had seizures with the use of the external stimulator that was provided immediately post-op. A 97% reduction in tinnitus in properly selected patients, though, is quite impressive and supports further investigation into this technology. Other less invasive modes of stimulation have also been explored. Because cochlear implants and ABIs improve tinnitus, it's been hypothesized that other types of direct stimulation to the cochlea may be effective. This is a clinical trial just published last year by the group at Mayo. They delivered electric stimulation to the promontory using a standard transtympanic stimulator placement. This is shown in the 2 photos. The first shows a placement of the electrode through the tympanic membrane, and the second shows the tip of the electrode on the promontory when viewed through the facial recess. Their study included 22 patients with unilateral or asymmetric tinnitus. The tinnitus was chronic, lasting 6 months to 3 years, and patients had already failed other interventions such as masking, tinnitus retraining therapy, or other interventions. They also could not be on any anti-anxiety or depression medications or have evidence of either condition on pre-study screening. The treatment was delivered for 10 minutes at 80% of the maximal comfort threshold stimulus, and this was done once a week for 3 weeks. The THI questionnaire was completed immediately after the study period and again at 3 months. All 22 patients in this study had clinically significant reduction in THI. The average improvement was 31 points, and a large percentage of their patients had complete resolution or no longer found their tinnitus to be debilitating, which was very encouraging. After 3 months, though, most patients had returned to near their pre-treatment levels of tinnitus. This trial laid the groundwork, though, for a potential implanted device that could deliver stimulation to the promontory over the long term without requiring in-person sessions and repetitive placement of the transtympanic electrode. And the group at UC Irvine has also published proof of concept ideas for electrical stimulation to the ear via different means. They used non-invasive stimulation, in which a probe is placed in the ear canal, or minimally invasive stimulation, which they place a probe on the promontory or round window niche through a myringotomy incision. They tested 10 patients in a total of 19 different conditions with varying levels, patterns, and durations of stimulation. This image in this center shows kind of an ideal result where the stimulus is shown here in blue and the tinnitus loudness is shown in red. So the stimulus is presented at a much lower level than the tinnitus level, and tinnitus loudness decreases over the course of therapy. Of the 19 conditions that were tested, 63% produced an improvement in tinnitus, 1 to 5% worsened the tinnitus. And this paper also describes some of the side effects, including sensations of tingling, vibration, or pain, visual sensations, and vestibular responses. So on the right is the treatment pathway that they envision for patients. They should try sound therapy first. If ineffective, move on to non-invasive stimulation, including just the ear canal probe. If that is ineffective, move on to minimally invasive stimulation, which again includes a myringotomy and placing an electrode on or near the round window. If still not effective, then move on to something invasive like a cochlear implant, ABI, or other novel implanted device. So these two devices stimulate the auditory system directly, but others have taken advantage of bimodal neuromodulation. So the concept of bimodal neuromodulation has gained popularity recently with several devices becoming available or soon to become available. These combine sound stimulation with additional central input of some type. Combining the two stimuli is thought to derive therapeutic plasticity within the auditory pathway and reduce tinnitus burden. Pilot studies have shown this is possible. It's been successful in other conditions such as depression, anxiety, seizures, memory loss, and chronic pain. These devices take advantage of stimulated neurotransmitter release or afferent somatosensory pathways, which have direct connections to the dorsal cochlear nucleus. Because of the plasticity of the system, some stimulation patterns can drive hyperactivity and contribute to tinnitus production. Other patterns can lead to tonic inhibition and decrease tinnitus. One of the first devices was a combined vagal nerve and auditory stimulus. The vagal nerve stimulation is thought to trigger a timed burst of neurotransmitter release. Tones were chosen at frequencies surrounding the tinnitus frequency to reduce synchronous activity in the hyperactivity tinnitus region. In the study by Tyler et al. Out of Iowa, they implanted 30 patients with a vagal nerve stimulator and treated them with paired vagal stimulus and tonal therapy delivered via headphones in an attempt to modulate their plasticity. So during the study, all the patients were implanted with a vagal nerve stimulator. Half were randomized to sham treatment for 6 weeks up front, and then they were allowed to cross over to the active arm. After the 6-week period, there was an increased rate of improvement in the treatment group that received paired stimulus compared to the control group. They considered an improvement to be a decrease by 20% in the TFI score. So this improvement was seen in 50% of the treatment group and only 28% of the control group during the initial treatment phase. After this initial study period, patients in both groups were allowed to continue using their devices. At 1 year, 2/3 of the patients were still using them on a regular basis. 56% reported ongoing tinnitus benefits. Vagal nerve stimulators are safe and generally well tolerated, but this is quite invasive. In the study, 2 patients had vocal cord paralysis that lasted for more than 3 months. One was temporary and resolved spontaneously, but the other was unfortunately permanent. And 2 other patients had the devices removed within the first year for other reasons. The next device was designed by a group out of Michigan, again headed by Dr. Susan Shore. This paper was published in 2018 by the group and explored paired somatosensory and auditory stimulus. This was based on results out of a guinea pig model and directly translated to human applications. The study had 10 patients, all of whom have somatic tinnitus. So about 60% of patients have somatic tinnitus, which means that they can modulate the pitch or the volume of tinnitus by clenching their teeth, by pressing on certain areas of their head or neck or scalp, for example, which again highlights some of the afferent inputs from these centers to tinnitus modulation. A sham crossover design was utilized. Treatments included paired audio tones with the placement of surface electrodes on the skin of the neck or cheek to stimulate somatosensory inputs. When delivered at appropriate intervals, the stimulus can be inhibitory and lead to long-term depression of the cochlear nucleus activity. This is just showing their crossover study design and some of their initial results. So there was a significant improvement in both tinnitus loudness and the TFI in the active treatment group, shown in purple, compared to the sham group in green. So this first stage only included 10 patients. A stage 2 study with 99 participants was just completed, but the results have not yet been published. And there are plans for a commercial device under the company Oracle Inc., which will include a generator with attached earphone to deliver acoustic stimulus and surface electrodes that patients will place on their neck or cheek. The linear device was just granted de novo approval by the FDA in March of this year and is produced by Neuromod Devices out of Dublin, Ireland. Their US collaborators are at the University of Minnesota. This utilizes trigeminal stimulation from the anterior tongue combined with sound therapy. This is a sketch of the device showing a patient holding the tongue stimulator in place. The treatment regimen is 60 minutes per day for a 12-week treatment program. This was a randomized controlled trial in which patients were randomized into 3 groups. The groups were defined by the delay between the broadband noise and the tongue stimulation, and the mapping of the tongue stimulus varied between the three groups. The first graph shows the change in TFI over time. So this gray area here at the beginning shows the 12-week treatment phase, and then changes in TFI were plotted for the year following the treatment phase. So this is weeks from the start of the trial. You can see a statistically significant change in all three groups compared to baseline. This is about a 10 to 15 point change in TFI, which is also clinically significant. And the next figure shows improvement in all three arms in the THI. So the final THI is plotted along the y-axis and the baseline values along the x-axis. So points inferior to the diagonal line indicate an improvement. The majority of patients improved in all three groups, 86% in arm 1, 89% in arm 2, and 84% in arm 3. So this treatment schedule is fairly time consuming, holding this on your tongue for an hour per day, but non-invasive because nothing is surgically implanted. There were no significant safety events. There were a few reports of temporary metallic taste and a small fissure on the buccal mucosa that were likely treatment related. But since this device was just granted initial approval by the FDA, it will likely become more readily available in the near future. So we have covered a lot of treatment options in a short amount of time, some that seem to be beneficial and others that don't. So what comes next and what should we be telling patients? So currently the workflow is to begin with a clinical evaluation, including a physical exam and audiogram, obtaining imaging when appropriate for unilateral tinnitus or other concerning features, offer appropriate therapy, which includes correction of conductive hearing loss, recommendation of hearing aids, cochlear implants, or ABI when appropriate, and providing education about tinnitus, which is really important for patients to understand the causes and the pathophysiology of what's happening. Acknowledgement of the severe impact that tinnitus can have on quality of life and mental health, and providing appropriate referrals, including addressing pre-existing anxiety and depression, recommendation of sound therapy when appropriate, recommending CBT to anyone with significant quality of life impact, and being knowledgeable about other treatment options like TMS or other emerging therapies and how to enroll in clinical trials. So several of the treatment categories show promise, but knowing which to recommend to which patient is not always clear. It's unclear who will benefit the most from CBT, sound therapy, just simple masking, TMS, or other novel therapies. And there are likely other associated factors which will help determine which therapy is likely to help which patient. But to do this, tinnitus subtypes will need to be further developed and validated. There have been multiple attempts to classify patients based on tinnitus severity, degree of hearing loss, THI scores, the presence of somatic tinnitus, and others, but there's currently no ideal classification. So there was a paper just recently published by Janet Saridi, who reviewed the literature and just listed the many, many criteria that have been suggested as important for building tinnitus subtypes. So this includes non-tinnitus related variables as shown here. So this is demographic factors, lifestyle factors, ear and hearing health, mental health history, other symptoms that associate the tinnitus, chronic conditions, prior healthcare interventions, anatomic differences, and genetic factors. So there might be contributions from all these categories that can help distinguish certain groups of tinnitus patients from others. There are also tinnitus-specific characteristics that have been investigated, including factors surrounding the onset and timing of tinnitus, the characteristics of tinnitus itself, the sound and pitch, whether or not hyperacusis is present, tinnitus modulating factors, impact of tinnitus on the quality of life, prior treatments attempted, and somatic contributions. So there's ongoing work to determine which factors are the most important to define and classify tinnitus subtypes. And the goal would be to assign patients to a particular subtype based on which treatments are likely to be the most effective in regards to their tinnitus and supporting characteristics. So as we continue to explore treatment efficacy, future trials will need to be more inclusive. Many studies have been done in veterans, which is important, but represents a relatively homogeneous group of people with shared experiences. Overall, from the studies I reviewed, the participants were mostly male, even though tinnitus tends to affect women and men at relatively equal rates. Most clinical trials also exclude participants with active depression or generalized anxiety disorder and those with catastrophic tinnitus. It makes sense because researchers want to prove that their treatments are effective and they may be more likely to demonstrate improvement in those that don't have the severe comorbid health diagnoses. but this is the group who needs help the most, and we're lacking evidence about which treatment will be most effective by those that are most bothered by tinnitus. In the near future, as treatments emerge, I think we'll see changes to the clinical approach for new patients with bothersome tinnitus. We'll still begin with an auditory assessment and physical exam and treat hearing loss appropriately. But I think the new role for novel tinnitus medications will be in the immediate phase after sudden hearing loss or acoustic trauma. I envision that we'll be injecting patients with a combination of steroids and a tinnitus medication in the immediate phase to try to reduce ototoxicity and prevent the maladaptive plasticity changes before chronic tinnitus occurs. CBT should be discussed and recommended to anyone with comorbid anxiety and depression and those whose tinnitus is impacting their quality of life in any way. There's certainly a role for sound therapy and TRT, which can be done in conjunction with CBT. For many patients with bothersome tinnitus, these interventions will be enough to provide significant benefit. And there's already been one bimodal stimulation device approved in the US, and others are on the horizon. So we'll begin to get more questions from patients about their efficacy. Promising results were seen in these initial trials, but there will be additional information forthcoming on cost, safety, availability, generalizability, and long-term efficacy. Implanted devices are the most invasive, but they can be reserved for those who fail non-invasive interventions. This may include novel devices that provide promontory stimulation or repurposing cochlear implants or ABIs to provide inhibitory stimulation to the auditory cortex. I know that was a whirlwind of information, but thanks for your attention, and I'd be happy to take any questions or open things up for discussion.